Cerebral palsy and anoxic brain injury, so essentially both the same thing. Cerebral palsy refers to a specific group of neurological disorders and are usually caused by something that happens either during childbirth or during early childhood is usually where it develops, and it's some combination of either anoxic, metabolic, or ischemic brain injury. So basically a part of the brain is being deprived of oxygen blood supply that results in neurological deficits depending upon which part of the brain gets affected. And that's going to be the important thing here. So I have here listed some of the types of cerebral palsy that actually occurs. You have what's the most common type, which is the spastic or the hypertonicity, where the muscles are in a excited state. You have the other types. You have the flaccid, which is the hypotonia, which is the opposite of the hypertonicity. You have the ataxic, which involves a lot of coordination problems with voluntary movement. Then you have the dyskinetic, or what they also call the athioid. So athioid movement is a type of movement that's characterized by very slow, irregular movements that are involuntary. So it's another defect in voluntary movement. What ends up happening many times with these individuals, because of the neurological issues that are present, they typically end up with a lot of multiple surgeries, overuse injuries, and impairment in range of motion. And that's particularly for the spastic type, where the muscles are in a constant hypertonic state, in a constant state of contraction. So it's not unusual for these people to experience a lot of problems. We do not, as athletic trainers, we do not rehabilitate individuals with cerebral palsy. That's usually within the scope of practice of other allied health professionals. However, athletic trainers may encounter individuals who do participate in physical activities who do have possibly mild forms. Obviously, if you have a severe form of cerebral palsy, you likely won't be partaking in physical activity, but there is the chance that someone with a very mild form or moderate form could end up participating in a rigorous physical activity, and you may encounter them. So epilepsy and seizures. So seizures are an issue that happens when there's a sudden electrochemical discharge in the brain. Epilepsy is the condition where people suffer repeated seizures. So some people have seizures sometimes because of a known factor, but they don't have epilepsy. Epilepsy is the actual condition where people suffer repeat seizures. And there's different types of seizures that you can have. The categories break down. You have partial and generalized. Basically describes how much of the brain is involved. So partial involves part of the brain, generalized pretty much involves the whole brain. And then you have a petit mal versus a grand mal seizure. The grand mal seizure is typically, I guess I would say, what people think about when they think about seizures. So that's the tonic-clonic type seizure, the tonic being the postural rigidity that occurs, and then the clonic involves the convulsive contractions. A petit mal seizure is typically a smaller seizure where basically the person just kind of loses cognitive awareness. They may lose postural control. Many times it more or less looks like the person's just kind of giving a blank stare, and they kind of just, sort of more or less, for lack of a better way of putting it, snap out of it. They may be in the middle of talking, and then all of a sudden there's a long pause in their sentence. That would basically be what we'd classify as a petit mal seizure. Again, the cause here is typically an electrochemical discharge from the brain that could be caused by various things. Again, when someone suffers from recurrent seizures, the actual disorder is known as epilepsy. Now, as far as physical participation in activities, there's really no medical reason to keep individuals with a seizure disorder from playing sports. And in many cases, they show how exercise actually could inhibit seizures from happening. The only situations where you do have to be aware of is you have to be very cautious, obviously, with swimming. It's not contraindicated, but you do have to be very important to be aware of if you're, covering for a swim event, individuals that may have a seizure disorder. There is a restriction with motor sports for obvious reasons, so it would be contraindicated in the case of motor sports. But again, participation does provide a psychological benefit. There is an increased risk for emotional disturbances and suicide for individuals who have epilepsy or seizure disorders. And it's very important for athletic trainers to be aware of the individual's history, so how often they have seizures, and any side effects that their medicines have. So a lot of times the medications do have side effects, and actually sometimes what it ends up doing is it ends up causing the individual with epilepsy to stop taking them. So it's important to kind of work with the individuals and communicate with them to make sure that they continue to take their medications. Okay, so we're going to talk a little bit about the management of a seizure. First thing, that the biggest key is protect the person from harm. So if a person does suffer a seizure, make sure the area is cleared. You do not place anything inside the person's mouth. That's one of a big misconception. So protect them from harm, get equipment out of the way. You can put down like a towel or a pillow just to protect the person's head, but never insert anything in the mouth. Never try to force the mouth open. Because obviously the person, one, can possibly bite and possibly either break their teeth if you try sticking something in, or if your hand's there, they'll end up biting your hand. You can turn the person on their side just because of the fact that they may be, they produce a lot of saliva, so just to kind of keep their airway open. After the clonic stage is over, so after the convulsions are done, perform your assessment. As far as immediate management, if it is their first seizure or one lasting longer than 5 minutes, they should be referred. Just very important, just as you would with any urgent situation, make sure to check their cardiovascular and respiratory function before emergency transport would arrive. So looking at spinal cord trauma, basically you're going to be looking at when someone does suffer a spinal cord injury, basically what is going to be lost in the individual due to the injury. So you have to first look if they have a complete or incomplete. Anytime somebody has a complete spinal cord injury, all their voluntary and autonomic neural functions controlled by neurons distal to the injury are lost. So basically, whatever level the spinal cord gets damaged at, everything below that level will be lost permanently. If there's an incomplete injury, you may be able to partially preserve some of the function. Just depends on the extent of the damage. Many times it's what ends up happening with people who suffer spinal cord injury, it's the secondary damage that causes further injury. So it's not actual physical trauma to the spinal cord, but it's swelling and the inflammation that takes place when someone suffers an injury that causes a lot of the damage. So a lot of times what physicians will do if they suspect a spinal cord injury, they will administer steroids to limit the amount of inflammation that occurs, and many times that ends up being able to preserve some function. What we're commonly concerned with is the acute aspect of this, and because of the chances of in physical activity for individuals to suffer acute spinal cord trauma. So when an acute injury does occur, you do have cessation of neural function distal to the site occurring, also deep tendon reflexes getting reduced, and then the spasticity that could possibly develop. Many times, again, depending upon the level of spinal cord and how much, that is really what is going to dictate the amount of damage that gets done from a spinal cord injury. Spina bifida occulta is a condition where you do not have complete formation of the neural tube. So basically the vertebral arch and the meninges are not fully developed, and what happens is you end up getting herniation of part of either the meninges and or the spinal cord through where that area should be. I have a couple pictures of it on the upcoming slide where you can see how this actually looks. And basically what ends up happening is, depending on the severity, this is something that's typically discovered at birth. There is one exception to that we'll talk about in a little bit. But the more severe versions are typically detected at birth, and usually they require some sort of surgical intervention, and there can potentially be impairment, again, distal to the injury, so there could be varying degrees of disability. The one that typically is not discovered at birth is something called Spina Bifida occulta. The reason for that is with Spina Bifida occulta, there's no actual herniation of the neural structures. So with this, what actually ends up happening is many times is this almost gets discovered by accident in individuals who are young adults or older people who maybe they come in for a back injury and somehow it just gets determined that they have Spina Bifida occulta. So they discover it upon an x-ray just sort of randomly by someone who's had a back injury. So usually there's not usually any major issues associated with this. So usually what ends up happening is they usually end up just going through rehabilitation for their low back, and they kind of just proceed on. There's some particular signs of this that sometimes can indicate that somebody has spina bifida. The other thing that you might feel upon evaluation is that you'll notice that the spinous processes, you can't palpate them because they're not there at some level. But pretty much all of their motor function and everything is preserved. Like I said, a lot of times that ends up just getting more or less discovered incidentally when evaluating a low back injury. So here's a picture illustration of the different types of spina bifida. So you can see the spina bifida occulta, all the neural structures are pretty much where they need to be. You just don't have that neural arch formed. So you're looking at a sagittal cross-section of the spine and the vertebrae. You can see the area where the spinous process is missing. Now your other two, which do involve typically some level of disability and gets discovered earlier on, you have your meningeocele, which is basically when the meninges just herniates through, and then you have the myelinomeningeocele, where both the meninges and part of the spinal cord actually herniates through. So again, look at the signs and symptoms. You can see the varying degrees of disability that will occur with each of these types of spina bifida. Multiple sclerosis is a condition that involves intermittent inflammation in the central nervous system, and what ends up happening is due to that inflammation you develop plaques that basically lapse and reoccur, and what it eventually ends up doing is causing irreversible damage to the neurons in the central nervous system. And that part of that involves the demyelination. So we talked about what myelin is. It ends up causing those neurons to demyelinate and causes various degrees of disability. The etiology of this is unknown. We do think that there is a chance that there are autoimmune factors involved. So there's a possibility there. So again, it will affect various regions of the central nervous system, and there's no real standard pattern for this. Many people get varying degrees of disability, and it progresses differently in different individuals. So it's very important to note over time, different things will start to cause problems. They will start to have greater degrees of disability. So it's important to note as you're looking at the signs and symptoms and treatment chart for this, also make sure to note things that affect or cause the symptoms or causes the person to have greater degrees of disability. It is important to note that many times lifespan with these individuals is usually not affected unless it's a severe case, but they do get more and they do have greater disabilities as they grow older. Complex regional pain syndrome is a unique condition, and this is a condition that occurs when in a distal part of an extremity when there's constant sympathetic stimulation. So what happens is that the sympathetic nerve fibers get a constant stimulation. It's very common to see in any time you have certain type of joint injuries or limb trauma, particularly when there's lengthy immobilization. So this is one of the reasons why in rehabilitation you only immobilize when you absolutely have to. The sooner you can get somebody moving, or if somebody can move a body part, it's very important that they do that. various nerve root disorders and conditions that have peripheral neuropathy can cause this. And essentially what happens is, from this injury, these small fiber pain receptors, so the small fiber pain receptors that transmit pain to the nervous system, basically get overstimulated. So it gets to the point where the person gets very hypersensitive in the region, and usually the progression of this begins to start to happen where the limb will start to atrophy. They have poor vascular control, so the limb may actually feel cold and get very pale at times, which can cause varying degrees of disability. And it could, if it progresses, get to the point where the entire limb basically becomes non-functional. So it's very important that if you see signs and symptoms of this occurring early on when you're rehabilitating an injury in somebody, that this gets discovered and that you start to incorporate treatment measures to limit it, because the further it progresses, the more difficult it gets to be to treat. So just to talk about this a little bit further, and I actually am going to talk about some of the treatment involved with this, since it can occur very often in orthopedic injury. Again, prevention. Again, anytime you could encourage range of motion in an extremity, do it, particularly of the uninjured joints. We typically think that when one joint has to be immobilized, we have to basically leave the whole area alone. So, for instance, if you have an elbow injury, work on range of motion at the shoulder. If you can move the wrist, move the wrist. Anything you can move, and progress weight bearing on the lower extremity as quickly as you can. If somebody does develop complex regional pain syndrome, various things you could do: rhythmic weight bearing, gentle joint distraction, encouraging active range of motion, desensitization techniques, basically taking different types of textures and just touching the area, because literally what's going to happen is, if this progresses, or depending on how bad it gets, it could be that you literally can't touch the person's limb or body part area without it causing pain. So desensitization techniques, taking soft textures and just rubbing it against the skin, and then gradually progressing to different types of things. So maybe going from and this is just a quick example, going from maybe taking a cotton ball or a Q-tip or a cotton tip applicator and just gently rubbing it against the area, and then maybe progressing to, sometimes even people take progressing to a lighter sandpaper even, just to get them used to that rough texture. And there's various ways you can do that. Joint mobilizations work as well. TENS, which is your electrical stimulation for pain relief, can also be this. Very important, the treatment for this needs to be aggressive as it gets discovered early, because again, the further and further it progresses, that limb, they're gonna continue to lose function in that area.